Homeostasis implies that each and every cell in the body is continuously bathed in a local environment of constant composition that is optimal for cell function. In essence, the peripheral vascular system is a sophisticated irrigation system. Blood flow is continuously delivering nutrients to and removing waste products from the local intestinal environment throughout the body. The heart supplies the pumping power required to create flow through the system. Because of the heart action, pressure in the inlet, the aorta, of the vascular network is higher than that at its outlets, the vena cava. Everywhere within the vascular system, blood always flows from higher pressure to lower pressure according to well-known physical rules. Like water flowing downhill, blood seeks to travel along the path of least resistance. Consequently, the peripheral vascular system changes the resistance of its various pathways to direct blood flow to where it's needed. And this lecture begins with description of the mechanism responsible for the transport of dissolved substances through the vascular system and the movement of the substances and fluid from capillaries to and from the intestinal space. Next, the basic equation for flow through a single vessel is applied to the complex network or branches vessels that actually exist in the cardiovascular system. Then, the consequences of the elastic properties of the large diameter arteries and veins on overall cardiovascular system operation are considered. Finally, the principles of the routine clinical measurement of arterial blood pressure are presented along with conclusions about overall cardiovascular functions that can be made from the information. Substances are carried between organs within the cardiovascular system by the process of connective transport. The simple process of being swept along with the floor of the body in which they are contained. The rate at which substances is transported by this process depends solely on the concentration of the substances in the blood and blood flow, where x is the rate of transport of x mass time, q is the blood flow volume time, and x is concentration of substances in blood mass volume. It is evident from preceding equation that only two methods are available for altering the rate at which a substance is carried to an organ. First, change in blood flow through the organ, or second, change in the arterial blood concentration of the substances. The preceding equation might be used, for example, to calculate how much oxygen is carried to certain skeletal muscle each minute. Note, however, that this calculation would not indicate whether the muscle actually used the oxygen carried to it. One can extend the convective transport principle to determine a tissue's rate of utilization or production of a substance by simultaneously considering the transport rate of the substance to and from the tissue. The relationship that results is referred to as the Fith principle and may be formally stated as follows, where XTC is the transcapillary efflux rate of substance mass time, Q the blood flow volume time, and XAV the arterial and venous concentration of substance. The Fick principle demonstrates that the amount of substance that goes into an organ in a given period of time minus the amount that comes out must equal the tissue utilization rate of that substance. If the tissue is producing substance X, then the above equation will yield negative utilization rate. Recall that one method for determining cardiac output used a Fick principle to calculate the blood flow through the systemic circulation. In that case, the known variables included the systemic tissue oxygen consumption rate and the concentration of oxygen in arterial blood and mixed venous blood, and the above equation was rearranged to solve for the blood flow. Capillaries act as efficient exchange sites where most substances cross the capillary walls by passive diffusion from regions of high concentration to regions of low concentration. There are four factors that determine the diffusion rate of substance between the blood and the intestinal fluid. First, the concentration differences. Second, the surface area for exchange. Third, the diffusion distance. Fourth, the permeability of the capillary wall to the diffusion substance represented as diffusion coefficient. These factors are combined in an equation, Fick's first law of diffusion, that describe diffusion of a substance across a barrier. Capillary beds allow huge amount of materials to enter and leave blood because they maximize the area across which exchange can occur while minimizing the distance over which the diffusion substances must travel. Capillaries are extremely fine vessels with a lumen inner diameter of about 5 micrometer, a wall thickness of approximately 1 micrometer, and an average length of perhaps 0.5 millimeter. For comparison, human hair is roughly 100 micrometer in diameter. Capillaries are distributed in incredible numbers in organs and communicate intimately with all regions of the interstitial space. Diffusion is tremendously powerful mechanism for material exchange when operating over such a short distance and through such a large area. We are far from being able to duplicate. In an artificial lung or kidney, for example, the favorable geometry for diffusional exchange that exists in our own tissue. As diagrammed in the figure, the capillary wall itself consists of only a single thickness of endothelial cells joined to form a tube. This ease with which a particular solute crosses the capillary wall is expressed in parameter called its capillary permeability. Permeability takes into account all the factors: diffusion coefficient, diffusion distance, and surface area, except concentration difference that affect the rate at which a solute crosses the capillary wall. Two fundamental distinct pathways exist for transcapillary exchange. Lipid-soluble substances, such as the gases oxygen and carbon dioxide, cross the capillary wall easily, because the lipid endothelial cell plasma membranes are not significant diffusion barrier for lipid-soluble substances. Transcapillary movement of these substances can occur through the entire capillary surface area. The capillary permeability to small polar particles such as sodium and potassium ions is about 10,000-fold less than the for oxygen. Nevertheless, the capillary permeability to small ions is several orders of magnitude higher than the permeability that would be expected if the ions were forced to move through the lipid plasma membranes. It's therefore postulated that capillaries are somehow performed at intervals with water-filled channels or pores, which may actually be clefts between the endothelial cells. Calculations from diffusion data indicate that the collective cross-sectional area from pores relatively to the total capillary surface area varies greatly between capillary in different organs. Brain capillaries appear to be very tight, have few pores, whereas capillaries in the kidneys and fluid production glands are much more leaky. On the average, however, pores constitute only a very small fraction of total capillary surface area, perhaps 0.01%. This area is nevertheless sufficient to allow very rapid equilibration of small water-soluble substances between the plasma and interstitial fluids of most organs. Thus, the concentration of inorganic ions measured in a plasma sample can be taken to indicate their concentration throughout the entire extracellular space. In general, albumin and other large plasma proteins cannot easily cross capillary walls. The precise mechanism for the low capillary permeability to proteins is in dispute. One hypothesis is that capillary pores are just physically smaller than the diameter of plasma protein molecules. Whatever the mechanism, the result in that much higher proteins concentration normally exists in blood plasma than in interstitial fluid. In addition to forming capillaries, a layer of endothelial cells lines the entire cardiovascular system, including the heart chambers and valves. Because of their ubiquitous and intimate contact with blood, endothelial cells have evolved to serve many functions in addition to acting as barrier through transcapillary solute and water exchange. For example, endothelial cell membrane contains specific enzymes that convert some circulating hormones from inactive to active forms. Endothelial cells are also intimately involved in producing substances that lead to blood clot formation and the stemming of bleeding in the event of tissue injury. Moreover, and as will be discussed in the next, the endothelial cells lining muscular vessels such as arterioles can produce vasoactive substances that act on the smooth muscle cells that surround them to influence arterial diameter. In addition to providing diffusion pathway for polar molecules, the water-filled channels that traverse capillary walls permit fluid flow through the capillary wall. Net shifts of fluid between the capillary and interstitial compartments are important for a host of physiological functions, including the maintenance of circulating blood volume, interstitial fluid absorption, tissue edema formation, and saliva, sweat, and urine production. Net fluid movement out of capillaries is referred to as filtration, and fluid movement into capillaries is called reabsorption. Fluid flow through the transcapillary channels is response to a pressure differences between the interstitial and intracapillary fluids according to the basic flow equation. However, both hydrostatic and osmotic pressure influence transcapillary fluid movement. The hydrostatic pressure inside capillaries is about 25 mm per mercury and is the driving force that causes blood to return to the right heart from the capillaries of systemic organs. In addition, however, the 25 mm per mercury hydrostatic intracapillary pressure tends to cause fluid to flow through the transcapillary pores into the interstitium, where the hydrostatic pressure is near 0 mm per mercury. Thus, there is normally a large hydrostatic pressure difference favoring fluid filtration across the capillary wall. Our entire plasma volume would soon be in the interstitium if there were no some counteracting force tending to draw fluid into the capillaries. The balancing force is an osmotic pressure that arises from the fact that plasma has a higher protein concentration than interstitial fluid. Recall that water always tends to move from regions of low to regions of high total solute concentration in establishing osmotic equilibrium. Also, recall that driving force for osmotic water movement between one solution and another can be expressed as osmotic pressure differences between the two. The osmotic pressure difference is directly related to the differences in total solute concentration in the two solutions in question. Because plasma and interstitial fluid are essentially identical except for their protein concentrations. Plasma proteins are primarily responsible for the net osmotic pressure difference across capillary walls. The component of total osmotic pressure due to protein has been given the special name oncotic pressure or colloid osmotic pressure. Because of plasma proteins, the oncotic pressure of plasma is about 25 mm per mercury. Due to the absence of proteins, the oncotic pressure of the interstitial fluid is near 0 mm per mercury. Thus, there is normally a large osmotic force for fluid reabsorption into capillaries. The relationship among the factors that influence transcapillary fluid movement, known as the Starling hypothesis, can be expressed by the following equation, where Pc is the hydrostatic pressure of intracapillary fluid, pi c the oncotic pressure of intracapillary fluid, Py and pi y the hydrostatic and oncotic pressure for interstitial fluid, respectively, and K a constant expressing how readily fluid can move across capillaries, essentially the reciprocal of the resistance to fluid flow through the capillary wall. Fluid balance within a tissue, the absence of net transcapillary water movement, occurs when the bracketed term in this equation is 0. This equilibrium may be upset by alterations in any of the 4 pressure terms. In most tissues, rapid net filtration of fluid is abnormal and causes tissue swelling as a result of excess fluid in the interstitial space, edema. For example, a substance called histamine is often released in damaged tissue. One of the actions of histamine is to increase capillary permeability to the extent that protein leak into the interstitium. Net filtration and edema accompany histamine release in part because the oncotic pressure differences is reduced below normal. Transcapillary fluid filtration is not always detrimental. Indeed, fluid-producing organs such as salivary glands and kidneys utilize high intracapillary hydrostatic pressure to produce continuous net filtration. Moreover, in certain abnormal situations such as severe loss of blood volume through hemorrhage, the net fluid reabsorption accompanied diminished intracapillary hydrostatic pressure helps restore the volume of circulating fluid. Despite the extremely low capillary permeability to proteins, these molecules, as well as other large particles such as long-chain fatty acids and bacteria, find other way into the intestinal space. In such particles are allowed to accumulate in the interstitial space, filtration force will ultimately exceed reabsorption forces, and edema will result. The lymphatic system represents a pathway by which large molecules re-enter the circulating blood. The lymphatic system begins in the tissue with blind and lymphatic capillaries that are roughly equivalent in size to but less numerous than regular capillaries. These capillaries are very porous and easily collect large particles accompanied by interstitial fluid. This fluid, called lymph, moves through the converging lymphatic vessels, is filtered through lymph nodes where bacteria and particulate matter are removed, and re-enters the circulatory system through the thoracic duct near the point where the blood enters the right heart. Flow of lymph from the tissue towards the entry point into the circulatory system is promoted by the first increases in tissue interstitial pressure due to fluid accumulation or to movements of surrounding tissue. Second, contraction of the lymphatic vessels, and third, valves located in the vessels to prevent backward flow. Roughly 2.5 liters of lymphatic fluid enters the cardiovascular system each day. In the steady state, this indicates a total body net transcapillary fluid filtration rate of 2.5 liters per day, when compared with the total amount of blood that circulates each day about 7,000 liters. This may seem like insignificant amount of net capillary fluid leakage. However, lymphatic blockage is a very serious problem and is accompanied by severe swelling, lymphedema. Thus, the lymphatic play a critical role in keeping the interstitial protein concentration low and removing excess capillary filtrate from the tissues. Previously, it was asserted that the basic flow equation may be applied to networks of tubes as well as to individual tubes. The reason is that any networks of resistance, however complex, can always be reduced to a single equivalent resistor that relates the total flow through the network to the pressure differences across the network. To do so, one must make use of the two equations below for series and parallel networks of individual vessels. When vessels with individual resistance R1, R2, Rn are connected in series, the overall resistance of the network is given by the following formula. Figure shows an example of three vessels connected in series between some region where the pressure is P1 and another region with a lower pressure P0, so that the total pressure differences across the network, delta P, is equal to Pi minus Po. By the series resistance equation, the total resistance across this network, Rs, is equal to R1 plus R2 plus R3. By the basic flow equation, the flow through the network Q is equal to delta P divided by Rs. It should be intuitively obvious that Q is also the flow volume divided by time through each of the elements in the series is indicated in the figure. Fluid particles may move with different velocities, distance divided by time, in different elements of the series network, but the volume that passes through each element in a minute must be identical. As shown in the figure, a portion of the total pressure decrease across the network occurs within each element of the series. The pressure decrease across any element in this series can be calculated by applying the basic flow equation to the element. For example, delta P1 means Q multiplied per R1. Note that the largest portion of the overall pressure decrease will occur across the element in the series with the largest resistance flow. As indicated in the figure, when several tubes with individual resistance R1, R2 are brought together to form a parallel network of vessels, one can calculate a single overall resistance for the peripheral network, Rp, according to the following formula. The total flow through a parallel network is determined by delta P divided by Rp. As the preceding equation implies, the overall resistance of any parallel network will always be less than that of any of the elements in the network. In the special case where the individual elements that form the network have identical resistance Rx, the overall resistance of the network is equal to the resistance of an individual element divided by the number of parallel elements in the network. In general, the more parallel elements that occur in the network, the lower the overall resistance of the network. Thus, for example, a capillary bed that consists of many individual capillary vessels in parallel can have a very low overall resistance to flow even through the resistance of a single capillary is relatively high. As indicated in the figure, the basic flow equation may be applied to any single elements in the network or to network as a whole. For example, the flow through only the first element of the network Q1 is given by Q1 means delta P divided R1, whereas the flow through the entire parallel network is given by Qp means delta P divided by Rp. It's important to make the distinction between blood flow volume divided time and blood flow velocities distance divided time. In the peripheral vascular system, linear velocity of flow at any point is equal to the flow divided by the cross-sectional area. Consider the analogy of the stream whose water moves with greater velocity through shallow rapids than it does through adjacent deep pool. The volume of water passing through the pool in a day, however, must equal the passing through the rapids in the same day. In such a series arrangement, the flow in the same at all points along the channel, but the flow velocity varies inversely with the local cross-sectional area. The situation is the same in the peripheral vasculature, where blood flows most rapidly in the region with the smallest total cross-sectional area, and most slowly in the regions with the largest total cross-sectional area, the capillary beds. The important consequence of the slow flow through the capillaries is that it allows sufficient time for adequate solute and fluid exchange between the vascular and intestinal compartments. Blood normally flows through all vessels in the cardiovascular system in orderly, streamlined manner called laminar flow. With laminar flow, there is parabolic velocity profile. Across the tube, velocity is fastest along the central axis of the tube and falls to zero at the wall. The concentric layers of fluid with different velocities slip smoothly for one another. Little mixing occurs between fluid layers so that individual particles move in strange streamlines parallel to the axis of the flow. Laminar flow is very efficient because little energy is wasted on anything by producing forward fluid motion. Because blood is viscous fluid, its movement through vessels exerts a shear stress on the walls of the vessel. This is a force that wants to drag the inside surface of the vessel along with the floor. The endothelial cells that line the vessel are able to sense changes in the rate of blood flow through the vessels by detecting changes in the shear stress on them. Shear stress may also be important factors in certain pathological situations. For example, atherosclerotic plaques tend to form preferentially near branches of large arteries where, for complex hemodynamic reasons beyond the scope of this text, high shear stress exists. When blood is forced to move with too high velocity through a narrow opening, the normal laminar flow pattern may break down into the turbulent flow pattern. With turbulent flow, there is a much internal mixing and friction. When the flow within a vessel is turbulent, the resistance to flow is significantly higher than the predicted from the Poiseuille equation. Turbulent flow also generates sounds which can be heard with the aid of stethoscope. Cardiac murmurs, for example, are manifestations of turbulent flow pattern generated by cardiac valve abnormalities. Detection of sounds from peripheral arteries, bruits, is abnormal and usually indicates pathological reduction of the large vessels cross-sectional area or an abnormally high blood flow through an organ. Second traits in a figure show the approximate percentage of the total circulating blood volume that is contained in the different vascular regions of the systemic organs at any instant. Note that most of the circulating blood is contained with the veins of the systemic organs. This diffuse but large blood reservoir is often referred to as a peripheral venous pool. A second but smaller reservoir of venous blood, called the central venous pool, is contained in the great vein of the thorax and the right atrium. When peripheral veins constrict, blood is displaced from peripheral venous pool and enters the central pool. In increasing the central venous volume and thus pressure enhances cardiac filling, which in turn augments stroke volume, according to the Starling's law of the heart. This is an extremely important mechanism of cardiovascular regulation. Blood pressure decreases in the consecutive segments with the pattern shown in the third trace on figure. The average pressure in the arch of the aorta, however, is about 100 mm per mercury, and this means arterial pressure decreases by only a small amount within the arterial system. As indicated onto the figure, arterial pulse pressure actually increases with distance from the heart, a phenomenon referred to as peripheral peaking of pulse pressure. The hemodynamic reasons for this are very complex but involve the positive addition of primary pressure waves produced by the heart that travel much faster than blood flow does, and reflected pressure waves traveling back toward the heart caused by discontinuities such as branching point in the arterial system. A large pressure drop occurs in the arterioles where the pulsative nature of the pressure also nearly disappears. The average capillary pressure is approximately 25 mm per mercury. Pressure continues to decrease in the venous and veins as blood returns to the right heart. The central venous pressure, which is the filling pressure for the right heart, is normally very close to 0 mm per mercury. The bottom trace in the figure indicates the relative resistance to flow that exists in each of the consecutive vascular regions. Because arterioles have such a large vascular resistance in comparison of the other vascular segments, the overall vascular resistance of any organ is determined to a very large extent by the resistance of its arterioles. Arterial resistance is strongly influenced by the arterial radius. Thus, the blood flow through an organ is primarily regulated by adjustment in the internal diameter of arterioles caused by contraction or relaxation of their muscular arterial walls. When the arterioles of an organ change diameter, not only does the flow to the organ change, but the manner in which the pressures decrease within the organ is also modified. The effect of arterial dilatation and constriction on the pressure profile within a vascular bed are illustrated in the figure. Arterial constriction caused a greater decrease in pressure across the arterioles, and this tends to increase the arterial pressure while it decreases the pressure in capillaries and veins. Conversely, increased organ blood flow caused by arterial dilatation is accompanied by decreases arterial pressure and increased capillary pressure. Because of the change in capillary hydrostatic pressure, arteriolar constriction tends to cause transcapillary fluid reabsorption, whereas arterial dilatation tends to promote transcapillary fluid filtration. The overall resistance to flow through the entire systemic circulation is called the total peripheral resistance. Because the systemic organs are generally arranged in parallel, the vascular resistance of each organ contributes to the total peripheral resistance, according to the parallel resistance equation. Arteries and veins contribute only a small portion to the overall resistance to flow through a vascular bed. Therefore, changes in their diameters have no significant effect on the blood flow through systemic organs. The elastic behavior of arteries and veins is, however, very important to overall cardiovascular function because they can act as reservoir and substantial amounts of blood can be stored in them. Arteries or veins behave more like balloons with one pressure throughout rather than a resistive pipes with a flow-related pressure differences from end to end. Thus, think on arterial compartment and venous compartment, each with internal pressure that is related to the volume of blood within it at any instant and how easily its walls can be stretched. This is characterized by a parameter called compliance. Given a follow that describes how much its volume change, delta V, is represents to a given change in the standing pressure delta P, which is the difference between the internal and external pressures on the vascular walls. It's apparent that the elastic properties of arteries and veins are very different. For the arterial compartments, the delta V divided by delta P, measured near a normal operating pressure of 100 mm per mercury, indicates a compliance of about 2 ml per millimeter mercury. By contrast, the venous pool has a compliance of over 100 ml per millimeter mercury, near its normal operating pressure of 5 to 10 mm per mercury. Because veins are so compliant, every small changes in peripheral venous pressure can cause significant amount of the circulating blood volume to shift into or out of the peripheral venous pool. Standing upright, for example, increases venous pressure in the lower extremities and promotes blood accumulation. Fortunately, this process can be counteracted by active venous contraction. The dashed line in the figure shows the venous volume pressure relationship that exists when veins are constricted by activation of venous smooth muscle. In constricted veins, volume may be normal, point C, or even below normal, point D, despite greater than normal venous pressure. Peripheral venous constriction tends to increase peripheral venous pressure and shift blood out of the peripheral venous compartment. The elasticity of arteries allows them to act as a reservoir on a beat-to-beat basis. Arteries play an important role in converting the pulsative flow output of the heart into a steady flow through the vascular beds of systemic organs. During the early rapid phase of cardiac ejection, the arterial volume increases because blood is entering the aorta more rapidly than it's passing into systemic arterioles. Thus, part of work the heart does in injection blood goes to stretching the elastic walls of arteries. Toward the end of systole and throughout diastole, arterial volume decreases because the flow out of arterioles exceeds flow into the aorta. Previously stretched arterial walls recoil to shorter lengths and in the process giving up their stored potential energy. This reconverted energy is what actually does the work of the propelling blood through the peripheral vascular beds during diastole. If arteries were rigid tubes that could not store energy by expanding elasticity, arterial pressure would fall immediately to zero with the termination of each cardiac ejection. Recall that the systemic arterial pressures fluctuates with each heart cycle between diastolic value and higher systolic value. Obtaining estimates of an individual systolic and diastolic pressures is one of the most routine diagnostic techniques available to be a clinician. The basic principles of the auscultation technique used to measure blood pressure are described as follows with the aid of figure. First, an inflatable cuff is wrapped around the upper arm with a recording device attached to monitor the pressure within the cuff. The cuff is initially inflated with air to a pressure usually 175 to 200 mm per mercury. That is well above normal systolic values. This pressure collapses all blood vessels under the cuff. The second, after initial inflation, air is gradually bled from the cuff so that the pressure within decreases slowly and steadily through the range of arterial pressure fluctuations. Third, the moment cuff pressure decreases below peak systolic arterial pressure, some blood is able to pass beneath the cuff during the systolic phase of the cycle. Because the flow through these partially compressed vessels is intermittent and turbulent, tapping sounds can be detected with stethoscope placed over the radial artery at the elbow. Sounds of varying characters, known collectively as Korotkoff sounds, are heard whenever the cuff pressure is between the systolic and diastolic arterial pressures. The highest cuff pressure at which tapping sounds are heard is taken as a systolic arterial pressure. Fourth, when the cuff pressure decreases below the diastolic pressure, blood flows through the vessels beneath the cuff without periodic interruption, and again, no sound is detected over the radial artery. The cuff pressure at which the sounds become muffled or disappear is taken as a diastolic arterial pressure. Mean arterial pressure is a critically important cardiovascular variable because it's average effective pressure that drives blood through the systemic organs. One of the most fundamental equations of cardiovascular physiology is that which indicates how mean arterial pressure is released to cardiac output and total peripheral resistance. The above equation is simply a rearrangement of the basic flow equation applied to the entire systemic circulation, with the single assumption that central venous pressure is approximately zero. Note that mean arterial pressure is influenced both by the heart, via cardiac output, and by the peripheral vasculature, via total peripheral resistance. All changes in mean arterial pressure results from changes in either cardiac output or total peripheral resistance. Calculating the true value of mean arterial pressure requires mathematically averaging the arterial pressure waveform over one or more complete heart cycles. Most often, however, we know from auscultation only the systolic and diastolic pressures, yet wish to make some estimate of the mean arterial pressure. Mean arterial pressure necessarily falls between the systolic and diastolic pressures. A useful rule of thumb is that mean arterial pressure is approximately equal to diastolic pressure, plus 1/3 of the differences between systolic and diastolic pressures. The arterial pulse pressure is defined simply as systolic pressure minus diastolic pressure. To be able to use pulse pressure to deduce something about how the cardiovascular system is operating, one must do more than just define it. It's important to understand what determines pulse pressure. That is, what causes it to be what it's and what can cause it to change. In previous section of this lecture, there was brief discussion about how consequence of the compliance of the arterial vessels arterial pressure increase as arterial blood volume is expanded during cardiac ejection. The magnitude of the pressure increased caused by increase in arterial volume depends on how large the volume change is and on how compliant the arterial compliance is. If for the moment the fact that some blood leaves the arterial compartment during cardiac ejection is neglected, then the increase in arterial volume during each heartbeat is equal to the systemic volume. Thus, pulse pressure is, to a first approximation, equal to systolic volume divided by arterial compliance. Arterial pulse pressure is about 40 mm per mercury in a normal resting young adult because systolic volume is about 80 milliliter and arterial compliant is about 2 milliliter per millimeter mercury. Pulse pressure tends to increase with age in adults because of decrease in arterial compliance. An increase in arterial stiffness, also referred to as hardening of the arteries or arteriosclerosis. This differs from atherosclerosis, which involves deposition of fat in the vessel wall. The increase in arterial stiffness with age is indicated by the steeper curve for the 70 years old than for the 20 years old. Thus, a 70-year-old will necessarily have a larger pulse pressure for a given systolic volume than 20-year-old. The increase in arterial stiffness is sufficient to cause increased pulse pressure even though systolic volume tends to decrease with age. Arterial blood volume and mean arterial pressure tend to increase with age. The increase in mean arterial pressure is not caused by decreased arterial compliance. However, because compliance changes do not directly influence either cardiac output or total peripheral resistance, which are the sole determination. Mean arterial pressure tends to increase with age because of age-dependent increase in total peripheral resistance that is controlled primarily by arterioles, not arteries. Arterial compliance also decreases with increasing mean arterial pressure. Otherwise, arterial compliance is a relatively stable parameter. Thus, most acute changes in arterial pulse pressure are the result of changes in systolic volume. Changes in total peripheral resistance, however, have little or no effect on pulse pressure because change in total peripheral resistance cause parallel changes in both systolic and diastolic pressure. A common misconception in cardiovascular physiology is that the systolic pressure alone or the diastolic pressure alone indicates the status of specific cardiovascular variable.